Hi. So thank you for inviting me to this conference. I do have something to say about elderly laughter, so you're going to see it in this presentation. I'm not talking about surgeries. I'm a clinical pharmacist, and I see different types of complications, and I think some of the cases you're going to see today is maybe going to be familiar to you, and I hope this is something you think about when you choose surgeries to patients. So at the end of this presentation, I also hope to give you some practical recommendations that you can take home to your patients. So I work in a hospital that we do many elective surgeries, and I can say that bariatric surgery is probably the surgery with most changes to chronic medications. I don't see any other surgery where a patient comes for 2 to 3 days and we change all of his home medications. And I do have a question. I actually added this 2 days ago. I was sitting here in the presentations and I didn't hear anyone thinking about medications as choosing the type of surgery you give to patients. So does anyone here in the audience think about what type of surgery to give patients when you choose based on medications? I would like to see hands. So I think in Israel, it's good to see, first of all. I think it's something that we talk more and more about in the last few years. And I don't see it, again, in studies, it's not something that you see a lot, but it is complications that we see later. And I would like to know also, does anyone consider medication side effect after surgery as a complication of surgery? Do you consider toxicity from a medication as a complication of surgery? I think a lot of the surgeons actually don't even see these patients. I think they do the surgery and those side effects and toxicities are treated in the ambulatory care setting and you don't even know about them. So I hope after this presentation you may have more awareness of this topic. So why do we have all these changes in medications? There are 3 main things that cause us to change medications. And I have to say I've seen patients that came and we changed up to even 10 of their chronic medications. And I think some of this is more obvious. The first and main issue that is not well studied is that the changes in absorption of medication. And we know that we change the GI tract, and that, when you think about it, potentially can change if a medication is less absorbed or actually more absorbed. The second reason to change medication is more common, right? So we give these patients the surgery to have remission of their diabetes and hypertension, and at some point we have to tell them which medication do you continue, which medication do you stop. And we know that certain medications like diuretics or medications in diabetes, we don't want to give these patients. So someone has to guide them and tell them what to continue and what to not continue. And actually, I had a conversation here in the conference with a surgeon, and the surgeon said, I don't tell them what to continue. I hope that primary care physician will do this. And when I talk to primary care physicians, they say, I don't know what to do after bariatric surgery. The surgeon should tell me what to do with the medication. And so I think this is a topic that really has not been well resolved between the community and the hospital. And the last reason we change medications is there are certain medications that we don't want to give after surgery. So I did mention diuretics, but there are several others that I will mention at this presentation. So just a quick overview about the absorption changes after surgery. I think the most important factor is the disintegration of the drug. So when we give a tablet or a capsule to a patient that had most of his stomach removed, we know that the volume of the stomach is smaller. So the stomach may not actually disintegrate the tablet or the capsule as well as you had a normal GI system or a normal stomach. So we know this actually may decrease absorption of medication. The second thing that happens is the pH of the stomach increases. And so for certain medications, we may see that it may decrease their absorption. But I will show you a case where the pH of the stomach increasing actually caused toxicity in these patients. And so we don't really know how this will affect the patient. And again, when we do bypass surgery, we bypass part of the intestine. And for many medications, this is a source of it's their absorption site. But on the contrast, there's we have metabolism occurring in the intestine, where we have PGP pumps and we have P450 enzymes. And so when we bypass this site, we may actually increase the absorption of medication. And so there are many errors going up and down, and so the net effect really is very specific to the drug, to the patient, and to the surgery. And even if you give the same medication and the same surgery to two patients, they may behave totally different. So I think really the take-home point in this presentation you will see is really monitoring, and teaching patients about the possible changes. And the problem is there are not many people dealing with this topic, and we see many presentations about bariatric surgery that is not in this topic. And so we have many small case reports. I try to publish, and many other people, but it's really, we don't have really good data. We don't have big prospective studies looking at this topic. So we did a review a few years ago. We tried to kind of collect everything we do know about medications, and if you can use this as a reference, there's a big table there kind of adding all the different papers looking at medications and how the surgeries can affect them. And again, they're mostly small, but we can see that there's definitely something there. The surgery does affect medications. So I'll present my first case. This is actually a recent case that we just published. Actually, it was just published in the last 2 weeks. I don't know if anyone there, maybe someone here was one of our reviewers. I know reviewer number 2, you were very difficult, but I don't know if you're here. It was in obesity surgery. So this was a 61-year-old male with bipolar disorder, and he's been stable on lithium for 10 years. We actually obtained all his past records, and we could see that his lithium levels was always normal. He never had toxicity. And he actually was chosen to have sleep gastrectomy. This was not in my hospital, but the thought of the surgeon was, if I give him a sleep gastrectomy, maybe he'll have less problems with the lithium. And so 2 months after surgery, his first ED visit, he came with general weakness, slowing in his behavior, and muscle weakness. And again, this is very confusing. The surgeon gave him, or I'm not sure if it was the surgeon or the ED physician, they gave him thiamine and fluids because it wasn't very specific. They never checked his lithium level. But when we did look at his records, we saw that a day before there was a lithium level checked and it was toxic at 1.6. But that was never actually looked at in the hospital. So months later, he came, and again to a different ED, and he's been stating that in the last 2 weeks he had severe weakness, severe general tremor, slow slurred speech, and occasional confusion. And in there, he was hospitalized, and his pulse kept coming down to the 30s with occasional asystole. And then they checked, when he was admitted, he hasn't been taking his medication for several days, and it was still super therapeutic. So at the end, they had to actually put a permanent pacemaker because they could not control his pulse. And his lithium dose was decreased, and I actually spoke to the patient. It's been a few months, and he's been doing well on the new lower dose. And this was actually, like I said, we just published this recently, and we also did a little review on this topic. And this has not been the first time it's been described. Lithium toxicity has been shown, mainly in Roux-en-Y bypass, but there was a case in sleep gastrectomy published before. We also had a very unfortunate case in Israel of death due to lithium toxicity post-sleep gastrectomy. And I think this is something that no surgeon would like to have. You know, you do beautiful surgery, but then the patient actually dies from a medication not being well monitored. So this was a table we put in our paper. So the take-home message for this is really close monitoring. In the case of lithium, the type of surgery really doesn't matter. All the surgeries that are common today will have the same effect of, or can have potentially the same effect of toxicity. And in general, what we know very little about psychiatric medications, and we know many of these patients need to be treated. They're treated before surgery, and they need to be treated after. But what we do know is They're very small studies. There was a pharmacokinetic study looking at SSRIs and SNRIs, which are very, very common in our population. And in all these patients, in most of those patients, 1 month after surgery, you could see a decrease of their level. And again, we never check SSRI levels in the blood post-surgery, so this is something we will see clinically, but in this article they did. And there were patients where the absorption of the drug went down even by 80%. And so this was actually correlated to clinical symptoms. But again, it wasn't all patients. Out of the 12, there are still 4 patients that had no change. So like I said, it really doesn't matter. It's very patient specific. And again, another study in escitalopram that showed a decrease in drug concentration. So again, just teaching the patient and telling them to be aware that there might be a decrease in their absorption of the medication, and that they need to know that if there's any change in their psychiatric symptoms or condition, they need to go and ask to increase the dose, and that's how we teach our patients. The other case is actually a Roux-en-Y gastric bypass for a patient that had, in his background, had a kidney transplant, also atrial fibrillation, and was treated with Coumadin. And 2 months post-surgery, he arrived at the ED with severe headache, with an INR of 12 and a bleed. And when I talked to the patient, he was discharged from the hospital on low molecular weight heparin, and he was instructed to resume his Coumadin outpatient, and there was no special instructions or warning given at discharge. And he actually resumed his Coumadin, and 8 days later, he did get an INR test that was within range. But then there were no other tests done until he came to the hospital with the event of the bleed. And this is again something we do have a little bit of articles on. We do know about Coumadin, and he had small studies, but this is a retrospective study looking 14 years back. They did find 27 patients, which is one of the biggest studies about drugs and bariatric surgery. And they checked it until 6 months, and most of the patients did need a decrease of the dose. And there is a thing about the 6 months, and we saw this also in the paper about the SSRIs. After 6 months, you see that a lot of the levels actually go back to be as they were before surgery. So a lot of the times the changes in absorption are in the first 6 months, and after 6 months, we have to go back to the dose before surgery. And again, there's a paper in Roux-en-Y, and they actually found an average of a decrease of about 10 milligrams of the Coumadin dose per week, which is very substantial. And again, in 6 months, you go back. So again, close monitoring, and don't forget that if you decrease the dose in 6 months, you have to check again and make sure you might have to increase the dose again. So we talked about Eliquis here, and again, a lot of the patients today are used by the new oral anticoagulants like Eliquis, Xarelto, and Pradaxa, but are they a better choice than Coumadin? And I would say most reviews, and there are 2 big reviews looking at this, would say we actually prefer Coumadin because at least we can check it. So there aren't any studies looking at absorption of these medications. There are 2 small studies. There was one pharmacokinetic study looking at Xarelto, rivaroxaban, in a dose that is given usually for, it's a lower dose post-hip knee replacements. And they gave 1 dose and checked for 24 hours later, and they saw that there wasn't any changes or alteration in the pharmacokinetic or pharmacodynamics. But then there was another paper that looked at 18 patients, and they had different types of surgery, and they compared them to controls, and this was 5 years post-surgery. And they actually showed that in all of the 3 drugs, the Cmax was lower. So when you do check for the DOACs levels, you check peak and trough. And so for all of them, this was 5 years later. It was still, the peak was lower, but it was most substantial both in peak and trough for Xarelto, which actually contradicts the first trial. So I think we really don't have any data about these medications, so we don't usually start them. But if we do give them, we ask for drug levels, which is very hard to get. It's an expensive level, and it's very hard to get it in the community, at least in Israel. It's not something that is easy to obtain. So actually, I'll finish. There are many, many drugs, and we can't talk about everything, but you have to be aware, and you want to make sure that your patient doesn't get any complications from these medications. So I'll just jump to the take-home message for this topic. I think everyone needs to be aware of this topic. I think if you do have someone in your staff, if it's a clinical pharmacist or pharmacologist, that can educate the patients before surgery. When I see patients, I actually see them before the surgery. They get what's called a medication discharge paper, and they know even before surgery how their medication is going to be changed, their diabetes medication, hypertension, if we're going to switch formulations. For psychiatric patients, if we do any changes to their formulation, we'll do it about a month or two before surgery because we want to make sure they're stable and that the surgery doesn't change everything. We never do the changes right after surgery. And I think there's definitely, if anyone here likes to publish, there are hundreds of papers that haven't been written about this topic, and there's so much more to learn. And again, like I said several times, clinical monitoring, teaching patients the signs and symptoms, having them do their own journals, teaching them that things can change after surgery, and I think this is really something that we should discuss more. This was published, actually the first time we put this in the international guidelines. We had a topic of medications in the last European guidelines, so I encourage this to happen more.
Thank you.
Thanks, Jen.